Thank you.
So
Thank
we
you.
go on to our next speaker, Dr. ADITYA Kelkar, who's a consultant, Raghudeep Eye Hospital, Ahmedabad. To talk on another interesting case.
Shall I share the presentation of Dr. ADITYA?
Yes,
Okay.
yes,
Yes, sir. Thank you, madam. Thank you, ARC. Thank you, AIOS, for this opportunity. It's an honor to be able to present. Sorry for having someone else share it. My bad. So this is a not uncommon situation these days, wherein often you combine a cataract and a retinal procedure, with the cataract surgery. And one of the things that is frequently done is
the video has to be shown. Dr. Anand?
Second, Dr. ADITYA, I'm just
no problem, ma'am. This was just an introduction.
I'm just
tell me. Yes, tell doctor.
Yeah. So this is about intravitreal injections or intravitreal implant injections, and this video is actually about what not to do during an intravitreal Ozurdex injection. So if we can just have the video. So this is a uveitic case. The cataract surgery has gone off uneventfully. Indeed, the IOL implantation has also gone off very well. And then the cataract surgeon himself has chosen to inject this intravitreal implant for cystoid macular edema. So this actually is a good procedure because it spares the patient the agony of having to go through a systemic therapy with corticosteroids. Now here what we see is that after an uneventful IOL implantation, the surgeon has chosen to remove the viscoelastic prior to the intravitreal injection. Now this is something you don't want to do unless you can assure yourself of a firm globe, because the Ozurdex needle is actually bigger than a 23 gauge vitrectomy needle. So here you can see that the surgeon is going in much like he would with a phaco probe with the bevel up, and you can see the IOL getting displaced by the needle, and the intravitreal implant has been inadvertently injected in the bag itself. So this has caused a posterior capsular rupture, and what was then planned in this case was a reverse optic capture to ensure that the haptics don't cause IOP rise, and at the same time we can assure the patient of a well-centered, stable intraocular without having to remove the single piece. So generally speaking, it is a good idea to use a viscodispersive to block the 3 ports before you inject Ozurdex, or you can remove the viscoelastic and have a very firm globe with adequate stromal hydration. But once you actually depress the globe with your needle, it will inadvertently, or it will inevitably rather give way and lead to hypotony. Is the video playing? Because I can't see it progress.
No, it has stopped playing.
Yeah, so this is now.
Yeah.
Hi. So now this is a post-reverse optic capture. This is stromal hydration. This is on post-operative day 7. You can still see the implant. Thankfully, the implant worked. It's not that the placement in the bag affected its pharmacodynamics. That's the thing. And finally, we have a UBM confirming the stability of the globe. So here, what was important is not just the visco removal, but also having the bevel downwards and perpendicular to the globe. And what you can actually do is when you go in, you can twist the needle away or towards the optic nerve and away from the IOL. So that ensures that this implant gets injected into the mid-vitreous cavity. That helps not only avoid, this nasty complication, but this is just a Miyake view of what actually happened in this case. So this avoids not only this complication of injecting in the bag and spoiling a very good cataract surgery, but it also ensures that the implant stays away from the pars ciliara and causes a relatively lower incidence of IOP rise. Because as we know, the closer the implant is to the pars ciliari, the higher the incidence of IOP rise. So thank you very much, madam, for this opportunity. And yes, I would love to discuss this further.
Yeah, I just wanted to ask you, Dr. ADITYA, there are reports of sometimes these implants migrating into the anterior chamber and corneal edema and toxicity and all that.
Yes.
So largely in this particular case, I think the optic of the IOL would prevent the Ozurdex from coming forward, right?
Yes, yes, absolutely. So in subluxated IOLs and all, madam, we have often, in fact, we have had to refer a patient for desec because the implant rubbed over the endothelium and caused corneal decompensation. And yes, these implants have, ended up everywhere, including subretinally in some cases. So one definite contraindication would be aphakia, but also scleral fixated lenses where you see a lot of gap between, say, the iris and the lens, or the lens and the vitreous cavity. So these implants, and especially in fluid vitreous, because these eyes have been inevitably undergone vitrectomy, and then that itself precludes that eye to anterior migration of the implant.
Dr. Gaurav,
stop sharing. Yeah.
Dr. Gaurav, are you there?
Yes, ma'am.
Now, would you use the same principle of having, if you had a PCR, would you think of doing a reverse optic capture for a toric IOL?
Ma'am, in the first place, if there was a PCR and I was given the choice of putting a toric lens, I would probably defer. I would not choose the toric IOL, but suppose my toric IOL was already in place and then I had a PCR like it happened in this situation, then I might resort to doing that. The thing is that, capturing optic capture in 3-piece lenses is very, very good. In single-piece lenses, sometimes it's more challenging, and especially if you have a rhexis which is a little tight, the haptic optic junction will kind of bend when you try to do this capture, and you may not have a stable capture, and sometimes the haptic will just bend, and it'll allow the haptic to kind of either come out anteriorly or go posteriorly depending on how you've captured it. So I would, in the first instance, not do an elective capture for a single-piece lens, but as a rescue, I would not mind doing it.
Okay, that's what I wanted to ask. And wonderful, Dr. Aditya. That was a very interesting video. Any other question before I go on to our last speaker?
Ma'am, there was one question.
Yes, sure.
In order to avoid certain complications like this, and especially in the presence of macular edema, would it be a better idea to have these in 2 different settings altogether? First, treat the edema, wait for a few weeks because the cataract was not very advanced anyways. So, and then do it as a second sitting after a few weeks. Probably the visual outcomes also will be better.
Yes, absolutely. That is a definite alternative.
Just for the take-home message for the
yes, absolutely. Yeah. So this is a definite alternative. And in fact, it can even be done after the cataract surgery, because then you're assured that your phacoemulsification and IOL implantation has gone off uneventfully. And, there is no rent or anything that would, again, predispose the eye to anterior migration of the thing. So this is just something, I think it's surgeon. It varies from surgeon to surgeon. And but in this case, the only thing that went wrong was the angle of entry, where you saw the bevel upwards. So even if the bevel, I think, had been downwards, in spite of the false angulation, the implant would have entered the vitreous cavity as opposed to the
even in cases where we do a cataract followed by a vitrectomy, many times if the chamber is not filled with viscoelastic, or if a suture has not been taken, for example, then when you are trying to make a vitrectomy port, again, there could be leakage of viscoelastic, hypotony, and there could be complications.
Yes, absolutely.
Then if at all it is done at the same sitting, then I think all those measures need to be taken to see that the globe is tight enough, viscoelastic filled, or a suture taken, which can be removed at the end of the surgery.
Yes. So even 3
along
sutures,
with the angle,
perhaps.
of course.
Yes, absolutely, ma'am. Even 3 sutures if need be.
Exactly.
To both the ports.
I wanted to say something, Dr. Ramurthy, sir.
Yeah, just a comment. A very pertinent observation, Dr. Nagar. But right now, intravitreal injections are overtaken cataract surgery as the primary as far as number of procedures concerned in the West, especially in the US. And I think as time goes on and as our population ages, the incidence is going to increase. And here you have a procedure which can be done, both can be done at the same time. And taking the patient back to the operation theater for doing a second time, and the first procedure not giving adequate visual rehabilitation, is really not correct. So I think it's very easy to master this intravitreal injection. Of course, giving a Avastin or some other Accentrix is more easier than giving a Ozurdex, but that's also something that we can easily learn. So doing it the right way is more important than rather splitting it up into 2 procedures. And my question to you, Dr. Sudhalkar, is that this happened right at the end of the surgery. And I don't know whether I missed something, but if the lens was stable and it was in the chamber, could you have just left it like this? Was a reverse optic capture necessary?
No, not necessarily, sir. So here, actually, the primary cataract surgeon thought that it would be better. But like you said, if the chamber, I mean, if the IOL is stable, after viscoelastic removal or perhaps stromal hydration, I'm sure it can be left in place the way it is. Just that post-operative, perhaps a delayed tilt cannot be ruled out. But in most cases, it does not happen. If it does not happen on table, generally it will hold true. So yes, sir, that is a definite option.
Yes.